Hi guys. So today we're going to do the other half of infectious disease, which is pretty much everything that's not an antibiotics. We're going to talk about antivirals, some antifungals, and a couple other random things. It's important to note that while some of these drugs we're going to talk about may be commonly used in certain situations, some of them are going to be really only reserved for specialty. We'll get into that in a little more detail, but just keep that in mind as we go through this. I'm going to talk a little bit about HIV treatment and medications used to treat HIV. Again, this is going to be something that probably you're only going to deal with if you're working in a specialty area. Now, as midwives, you may encounter populations who have are at risk for HIV, or you may be trying to suppress viral load during the peripartum period. Again, it's going to be something that probably is going to be, if you do focus in this area, you're going to probably be working with a specialty group of patients. So the general person, I would assume, is probably not going to see a lot of HIV treatment. So I have a lot of slides on this, and the reason is because there's a lot of HIV treatments. I'm going to tell you what I think the best things to focus on are, and the few drugs you should really know, and then the rest of it's kind of stuff I'm going to skip through pretty quickly. I've got a friend who works in HIV specialty, and he does a lecture for me in my PA course, and so these are all his slides that I borrowed, and I tried to narrow them down a little bit. But again, HIV is kind of a big topic in of itself, so we're going to go through it. But don't be alarmed if I'm moving at kind of a fast pace. I'll try and focus on what I really think is important here. Some background on HIV. It's a big deal if you didn't know that already. So there's a lot of people living with HIV and AIDS. There's a lot of new infections a year, and there's quite a few people that die a year due to HIV and AIDS. The good news is our drugs have gotten a lot better and have come really far even the last 10, especially the last 20 years. So people are able to take regimens now that are not only more effective at suppressing the virus's activity and basically making their viral loads undetectable in many situations, but also have much better side effect profiles than the past. So they're much better tolerated. They're much more convenient. Some of the regimens are just once a day, one pill once a day, which is great for compliance purposes. So HIV has come quite a ways, but you can see here based on these statistics, 54% of infected people are on antiretroviral therapy, and 50% with HIV don't even know they're infected. Now this is world data, so take that with a bit of a grain of salt, because there's different places, of course, that just don't have real good access to healthcare or access to resources like we would in the United States. When we look at Minnesota, you can see people living with HIV. This one showed about 7,500 people in Minnesota living with HIV. So that's a pretty decent sized patient population that we're caring for. And a lot of those are going to be probably in the Twin Cities metro area here. And you can see some other stats here that I'm not going to go into right now. But there's a lot of information on the Minnesota Department of Health website if you're interested in more of the local epidemiology. This diagram shows the major drugs we have and where they work. So integrase inhibitors, reverse transcriptase inhibitors, which there's a couple of those, and protease inhibitors are really the major ones. There's some fusion entry inhibitors, which I'm not really going to talk about. But the point of this diagram is to see that you can target multiple mechanisms of action. That's really the strategy. I mean, that's a strategy when we use a lot of infectious disease. When we're combining agents to treat something, we aren't combining things within the same class usually. Like, let's take antibiotics, for instance. You aren't going to give somebody 2 beta-lactam antibiotics because those are in the same class. If you want to give 2 antibiotics, you're going to combine things in different classes to get a synergistic effect. And that's the same way that it works for antiviral therapy and HIV in this case. So moving forward, just to talk about some goals with HIV therapy, the goal is to have an undetectable viral load. So ideally, if you went to the lab and you drew your blood, you wouldn't have any detectable HIV there. CD4 cells are the major target and the biomarker they use for determining how functional somebody's immune system is. So once you get a really low CD4 count, that's considered AIDS and so HIV infection causing autoimmune deficiency syndrome, or AIDS. And the goal is to keep people's CD4 cells within normal range so that they would be the same as anybody, whether they're infected with HIV or not. And if your viral load is undetectable, your CD4 count should come up, even if it's low at some point. So again, trying to get it normal, and looking at treatment that way. So like if somebody has an undetectable viral load and they have CD4 helper cells are in normal range, the question about treatment, and we'll go through some of this stuff too. So kind of ignore those little bullet points there for a second. HIV is rapidly replicated. It's a difficult virus to totally suppress, but again, our drugs are pretty good now. The acute infection, usually people have about 5 days to 3 months after exposure will experience like flu-like symptoms for anywhere from a short period of time, a couple of days, to up to 2 weeks. And profuse night sweats are one of the things that may be more prominent with an HIV infection than maybe another viral type syndrome. This generally isn't treated because people are just assume, they have some sort of virus. They maybe assume they have, got influenza or, I don't know, whatever it may be. They might think that they just got like some respiratory virus or something like that, when in fact they actually got infected with HIV. Okay, first slide here. And you can see we have Prozista, Icentris, and Tivicay all in combination with our other backbones. Raltegravir, So essentially, almost all of what we're using in our modern regimens in combination with either Truvada or Epsicom are going to be these drugs. So these have really become popular. They work quite well, and their side effect profile is very nice. That's really all I want to say about integrase strand inhibitors. I guess I should briefly speak to the mechanism. So integrase strand, integrase is an enzyme that changes the structure or function of an enzyme, rendering transfer of viral DNA to human DNA not possible. So you get incomplete proviral production is what they call this. So you're interfering with a different step. And if you want to see the visual, you can go back to that slide at the beginning and take a look at that. But again, the point is that integrase strand inhibitors, mostly extremely well tolerated. There's no major black box warnings. They don't have a ton of side effects to worry about, which are all great things when it comes to drugs, right? We want to limit the side effect burden on patients, and we want to provide a therapeutic alternative that works quite well. And these drugs have shown to be extremely effective. So with that being said, I'm worried about that one at the bottom. Some things I want to talk about. Pre-exposure prophylaxis is something that's come up a lot. This is people who are at risk, high risk for acquisition. So, a lot of that, I think the publicity on this process has been targeted at homosexual men, but in truth, heterosexual men and women who practice high risk sex or are IV drug users or whatever it may be are very at risk for HIV as well. So for women as well, this is something not to think about, is if you have patients who are in these situations where they might be putting themselves at risks. Exposure prophylaxis is kind of a new area of HIV prevention, and it's considered to be fairly effective. So Truvada once a day is approved for PrEP. So what you would do is take Truvada by itself once a day, which is interesting because it's not like you're taking a regimen to treat HIV, but they've been showing that Truvada just alone is enough. If it's circulating in your body and you happen to get exposed to the virus, it's enough to prevent any type of viral hold. And there's maybe some hope that people can avoid HIV infections altogether with this. Now, there's been some studies that show that this is somewhat effective. There's some arguments that say that this is problematic because people should be really using other forms of protection. And ultimately, they're probably both right. I think this is a great option for people who are at high risk of acquisition. But I think also it shouldn't really take the role. It should be used in conjunction with barrier methods, things like latex condoms and typical prophylactic methods like that. So protective methods like that. So ultimately, it's a tool in our arsenal, and it's something you may hear about, but it is an interesting kind of area of HIV prevention that's being explored right now. This is just a high-risk summary table in case you're interested. What is considered excuse me, yawn, and what would be considered a high-risk group of patients. So where we would be consider using these products for people. Now, post-exposure prophylaxis is a couple of different aspects to it. So timing of the exposure, if you're out of 72 hours, it's going to be less effective. So really the important thing is after you've been potentially exposed to HIV, you want to get treatment quickly. So there could be multiple ways you're exposed: IV drug use, sexual intercourse, and then maybe not knowing the status of the partner. If somebody gets assaulted, they probably have no idea on the status of the assailant, so there's no real way to tell that. So sometimes it's just purely you're saying, well, this person might have gotten assaulted and they might have been HIV positive, so we want to treat them prophylactically just to be on the safe side. For healthcare people, there's a lot of exposure risk too with needle sticks and stuff like that. It's the guidelines for healthcare exposure are a bit different as far as timeline and what to do, but the treatment is the same. So you're either using a 2 or a 3 drug regimen for treatment, and you'll see these drugs are very similar to our standard of care. Truvada plus raltegravir, if you remember, is one of our first line options, and this would be an option, and this is actually the preferred option for post-exposure prophylaxis for healthcare workers or for people who have been exposed in the community, whether it being IV drug use or sexual intercourse or what have you. All right, pregnant patients. So this is another interesting, probably more interesting to you guys than some of the other stuff I've talked about recently. But so for a pregnant patient with HIV, the question is, do they meet standard adult criteria for treatment? And you would start a potent 3-drug combination as soon as possible, even if they're in their first trimester. We don't really mess around with HIV treatment, and you wouldn't necessarily hold anything. Most of the drugs, while haven't been extensively studied in pregnancy, are thought to be reasonably safe to give in pregnant patients, especially most of the current regimens. You can see these stats I have over here. So AZT or Zidovudine is what that is the acronym for. We have a decreased risk of exposure of vertical transmission from mother to baby with people who are treated with that drug specifically. So the only real drug we want to avoid is efavirenz. We don't really use that anymore. That's why I skipped over it. So Zidovudine is a drug that I didn't really talk about a lot, but we'll mention here. It's the only one that we have that's IV. So you can give it IV at the time of labor, followed by continuous infusion until the umbilical cord is clamped, and that's been shown to reduce the risk of transmission substantially. And then you would treat the baby with Zidovudine for 6 weeks and consider other therapy. You could consider other therapy if the mother was not on therapy during pregnancy as well. So just think about it from a point of view of what was the mother taking? Was she on viral suppressant agents? And then you could maybe tailor a regimen that way. But Zidovudine by itself is usually used in this situation. Okay, so that's really it for HIV. We're going to move on to some other viral infections. And again, for HIV, I'd really just focus on those primary regimens, some of the key points I talked about, and I wouldn't get too worried about knowing every single drug on there, and just again, the big picture stuff is what's important. All right, herpes viruses. There's a whole bunch of them, and some of them we treat, some of them we don't. Here's just sort of a listing of all the herpes different types of viruses. You can see the mechanism here, where the HIV infected cell is trying to replicate itself. It takes up acyclovir instead of a base pair, and you end up with a chain termination during the DNA synthesis process. Acyclovir is the only IV HSV agent, which is important because if you want something that is not PO or your patient is not able to take oral products, this is really the only one you can give. It's got a pretty short half-life, so if you're dosing it orally for like a herpes simplex infection, you have to do it 3 to 5 times daily, which isn't very convenient at all. Roles, therapeutic roles, aseptic meningitis. It does get really good CNS penetration, which is a benefit it has. Genital oral herpes, chickenpox, although we usually use valcyclovir for oral therapy, and I'm going to get to that in a second here. It's pregnancy category B, and it has very few side effects. the possibility of kidney stones is there for the IV product because of the way it's formulated, but that's unusual. So most part, people tolerate it pretty well. Valtrex or valacyclovir is just the L-ester of acyclovir. So what happens is that it's just got better bioavailability. You're allowed the drug to get to absorb at a higher rate out of the GI tract. Therefore, you're getting higher blood concentrations because it's really converted to acyclovir very quickly as soon as it enters the bloodstream. But you're giving a lot more acyclovir into the bloodstream. So acyclovir itself doesn't absorb all that well out of the GI tract. Valacyclovir has much better bioavailability, gives you a higher serum concentration. It's just usually once daily to up to 3 times a day, depending on the treatment. So a little bit more convenient than regular acyclovir. It's a drug of choice for oral or genital herpes. Some people may be on chronic daily therapy for suppression, like if they have HIV and their CD4 count's low, or if they're immune suppressed potentially. Varicella zoster, you would dose it 3 times a day and give a little bit higher of a dose. It's oral only, so we don't have an IV form of valacyclovir. So if you really want an IV therapy, you have to give regular acyclovir. And it's usually, again, very well tolerated. And this drug is essentially acyclovir, so you could use it in pregnancy. I would consider it to be category B, regardless of what it says anywhere, because it really is the same thing. What's getting into your blood is acyclovir. It's just more of it. So it's a better way to get the drug into the body. It's really the same drug, though. Additional agents, I'm not going to spend a lot of time on these. There's a couple topical products. There's famciclovir, which I don't really have anything to add to. Abreva is the over-the-counter product you may or may not be familiar with. It's a topical product that prevents, that can help the healing of the lesion. It's really expensive and it doesn't have all that great a benefit. Maybe it will improve healing by 1 day or so. You want to start it early. People, if they feel like they have a cold sore coming on, usually will start it before the cold sore actually shows itself, and that can help decrease the impact of the actual cold sore itself. Hepatitis, something I want to touch base on quickly. We'll kind of blow through Hep A and B. Hep A has a vaccine. It's associated with poor water quality, and it's a short-lived thing. So usually people will have flu-like symptoms, GI symptoms for a short period of time, maybe a couple weeks at most, and then it should go away. It can involve more significant hepatocellular issues in more severe cases, but for the most part, it's a short-lived issue. Symptoms last up to 2 months potentially, but the bulk of it should be a fairly short thing. And there's no treatment. Symptomatic support is recommended. And then there's a vaccination for hepatitis A. So in most of the developed world, it's not a big deal because our water is fairly high quality. If you're going to places that are developing or have issues with water quality, just be smart like you would with anything. Wash your hands before meals, avoid contaminated food sources potentially, and drink water that you know is from a good source. Hep B, another one we're going to skip over. There's a vaccine for this, so this isn't really something we see as treatment again. So there's different phases, different ways you can contact it. It is a blood contact and mother-to-child contact. So again, why this is vaccinated. The first vaccination any baby will get will be in the hospital. That's to decrease the risk of potential healthcare-related exposure. Treatment of Hep B. It's very complicated, and there's a lot of decisions that you need to make if you're going to treat somebody for Hep B. It's a couple antiviral products that we have done there, and there's also a product called Interferon. Interferon products they work with the immune system. They're really expensive, and they have a lot of kind of nasty side effects. So Hep B treatment is there. And again, I'm not going to test you on it. I don't want you to know it. I don't want you to really even think about it all that much. But there are some options for people who do have hepatitis B that we might want to consider treating with. Now, Hep C is the other side of the hepatitis coin here. And this one is interesting for a number of reasons. First of all, we can cure hepatitis C in patients. And the drugs on the market, I think I mentioned some of these briefly during my first lecture, are some of the major sellers currently worldwide. So these are making tons of money for the drug companies, And there's a lot of ethical questions about these medications, but we'll talk about it here a little bit. So we've got a lot of people in the U.S. with Hep C. It does have a substantial cause of morbidity and mortality. You can put yourself at risk for liver-related complications, liver cancer, liver failure, etc. There's 6 genotypes, so the genotype can be confusing because some drugs only target certain genotypes. And so that's something we take into consideration. Acute infection, the patient is often asymptomatic usually. So, and after several months, they may have some similar symptoms like a Hep A or Hep B virus, but it takes a while for people to realize they have Hep C. All patients with acute infections will develop a chronic infection. So most patients who are exposed to the virus will develop some sort of a chronic Hep C. And it's unclear what patients are at higher risk for more faster versus slower progression to liver cirrhosis. So hepatitis C treatment, we have a couple different options, and excuse me, there's a few different things on this slide that we're going to talk about, but I really just want to to the next slide. There are these new HCV therapies. These are really the ones that are the blockbusters that we're seeing now. So let's talk about Harvoni first. This is the newest combo out on the market, and in fact, Hep C is such a growing area. I think there's like at least 5 or 6 new drugs or new combinations in process or on the market already. People are realizing that this is a huge moneymaker, and the fact that we've figured out really how to cure hepatitis C is pretty cool in of itself. So these drugs, Harvoni, I think one course of Harvoni costs like, I want to say it's like a couple $100,000. It's very expensive. But the drug companies justify it. They're like, well, we're curing a patient, so we're going to treat them for, a year or two, and they're going to be cured when they're done. Whereas, if we were treating HIV, we'd be treating them for life because they're never going to be cured. They always have to take their medication. So we have a whole lifetime of a patient to recoup costs and, to sell that drug. For this one, our patients are getting cured, so we have to recoup our costs on the front end. Now, whether you agree with that theory or not, that's kind of the gist of why they price them so aggressively. There's been a lot of commentary and controversy around, are these drugs just so overpriced that it's getting to the point of being ridiculous? But for the most part, I think healthcare advisory committees are agreeing that in the long run, it's less expensive to treat it with a really expensive drug than to deal with complications down the road. Sovaldi is another one that was that's the sofosbuvir component of Harvoni here, and that's also available. Sometimes you may see people on a Sovaldi combination. We're just going to be seeing more of these. There's this Viekira combination product that's out. It's a little bit less. It's not less effective than Harvoni, but it has some drug interactions to consider, and there's some other things too as well that I'm not too concerned about. So with Hep C therapies, I think the thing to know is that there are therapies out there. They're very effective. They're extremely expensive, but they are cures for the viral infection, which is pretty cool because we can't do that with a lot of things. Okay, influenza. Well, influenza affects a lot of people a year. Everybody is familiar with the yearly flu and the flu shots that come through every year. Annual healthcare burden is quite high. A lot of people actually can get really severely ill from influenza, and it's not necessarily because of influenza itself. It's usually because they get influenza, which is primarily a respiratory infection, and then they follow it up with some sort of bacterial pneumonia, and that's usually what causes people problems. So we had a couple people really sick in our ICU last year, and I'm not sure how it's been this year yet, but it was pretty sad actually. Relatively young, healthy patients who had influenza, and they got a comorbid like streptococcal pneumoniae infection, and it got to the point where we couldn't really the strep pneumoniae produces toxins, and no matter how many antibiotics you give, sometimes you can't suppress all of that, and ultimately you can get into a septic picture that's difficult to recover from. Generally with influenza, though, we think about highest rate of illness being our elderly population or a really young population, pregnant patients who are compromised, people with heart and lung disease, and immunosuppressed patients. And these are patients that are definitely at highest risk and should be vaccinated every year, along with everyone else, but especially these patients. Three major subtypes, the influenza A and B. H and N are abbreviations for hemagglutinin and neuraminidase, which are the surface proteins. So when you hear like H1N1, those are different types of surface proteins. That's how they differentiate the different serotypes of influenza virus. And so you hear, so what epidemiologists do is they predict based on what's going on in the world and where other people are seeing minor influenza outbreaks throughout the world, endemic outbreaks, what might be on its way to the US for a seasonal flu. And then they'll predict, okay, so we think that these are going to be the biggest serotypes. And we can only put so many within a vaccine at this point. Technology may change in the future where we might get the ability to have some sort of a universal flu shot, but at this point we don't have that. So we can usually cover 3 to 4 different types within a vaccination, and it's kind of a crapshoot in the sense that you don't know for sure. We do our best to predict with epidemiological data, but ultimately it could change, and then we have problems. So the other problem is that the virus does change year to year. So and not every 2 years will be the same specific type of the virus that's going to be likely to be the large pathogen that we're going to face. So it's a guess. It's an educated guess, still a guess. So when you hear reports that, the flu vaccine's not that effective this year, it seems like I hear that every single year. Well, yeah, I mean, it's never going to be 100% effective because it's very difficult to predict. Some years you may have a great prediction and you nailed it. Other years you may totally miss it completely, and then that's a problem. But the point is that the influenza vaccine gives you more protection than if you weren't to get it at all. So erring on the side of getting the shot is definitely important. Transmission, this is a respiratory infection. I know that probably everybody knows this, but when people say like, oh, I've got the flu, and they had a severe diarrhea and vomiting, that shouldn't really be a complication of influenza. It may sometimes be a component of it, but rarely is GI symptoms a significant component of influenza. Influenza, first and foremost, think about it as a respiratory infection. So people are going to transmit this via respiratory droplets. Incubation period's about 2 days once you've been exposed. Rapid onset of symptoms after the incubation period. So headache, fever, muscle pain, non-productive cough, sore throat, what we think of as a flu-like syndrome. That's everything there that you'd think of like your standard kind of viral syndrome. And then again, pneumonia, which could either be strep, and then I put classically it is MRSA, which I didn't mention in the other one. Strep pneumo can be nasty. MRSA, of course, can be a really nasty pneumonia too. So that's the big problem here, and that's why people usually end up in the ICU after they've had influenza, because they have some sort of bacterial pneumonia that's wreaking havoc in their respiratory tract. So prevention, get the vaccine. We talked about I talked about this in my last lecture. There's the IM version and the intranasal live attenuated version. Minimum, usually 50% reduction in influenza development, up to 70% reduction in hospitalizations due to influenza thanks to the vaccine. So regardless of what you hear about how effective it is or not, data over the years has shown that we are reducing cases of influenza and we are reducing hospitalizations due to the flu shot. Everyone ideally would get their shot by sometime October. Kids 2 months to 8 years will get 2 vaccines 4 weeks apart. There's a new product on the market that's like a high dose one that I don't have listed here. It's not specifically recommended yet, but it is designed for elderly patients who might not have as good of an immune response. It's a higher dose. It's a more not antigenic, but it's a more it's a product designed to produce a more significant immune response in a patient who has maybe a more waning immune system like our elderly populations. And there's, of course, other recommendations, lots of stuff on the CDC in case you're interested. Neuraminidase inhibitors, there are 2 of these on the market. The first one is probably one we're all familiar with, which is Tamiflu or Oseltamivir. It comes as an oral capsule and a suspension. It's a twice daily product for 5 days. And if somebody has been exposed to, so like let's say, you bring in your family member, they have a positive influenza test. You don't have any symptoms yet. You may get prophylactic once daily Tamiflu just to hopefully suppress the viral activity. These drugs, what they do is they're altering particle aggregation to each other in the cells, so they're preventing the viral particles from really activating fully, and ultimately should hopefully decrease the duration of symptoms and also the severity of symptoms over time. Early administration is really crucial. If you've been over 48 hours with flu symptoms and you're positive flu influenza, it's really not appropriate to prescribe Tamiflu. It just doesn't have any effect at that point, and you're basically giving somebody medication that's not going to do anything, so why prescribe it? It is approved in people ages 1 and older, and I think actually they've dropped this down to like even young infants can take this now. So I'm pretty sure that that's changed recently, but I forgot to look that up. So, but anyway, we use this in kids essentially of all ages. American Academy of Pediatrics has recommendations for 0 to 11 months. So they would use this in a child if they got influenza that is under 1. Zanamivir or Relenza is an inhaled product. And I don't see this used a whole lot, but it is a potentially other option. Some people think that this is maybe nice because it gets directly to the lungs and into the source. It has some problems with people who have breathing disorders underlying, so like asthmatics or COPD patients, and it's only indicated in older children or adults. Adamantanes are a couple different drugs. There's amantadine and rimantadine. What these are doing is they're blocking a channel to inhibit proper viral function, and they only work for influenza A. So where you might see amantadine used specifically would be, I feel like they like to use this during maybe like if there's a nursing home outbreak or like a community living outbreak where they know it's influenza type A. Maybe they've gotten, the first couple of people got tested, came back positive for influenza A. They may prophylax everybody with an amantadine type product. It's relatively cheap. If you know it's influenza A, it might be more effective than doing, and more effective and cheaper than doing Tamiflu. All right, a couple other random viral things, and then we'll get on to antifungals. So HPV, not really much to say about this. There's a vaccine, Gardasil. It covers the strains most common that cause genital and perianal warts, and also cervical, penile, and oral throat cancer, which are 6, 11, 16, and 18. There's like 100 different strains of HPV over, and they represent anything from the common, warts people get on their skin to cervical cancer. There's a topical product called Imiquimod or Aldera, which is modulates the immune system that can be useful for this. You have to apply it multiple times per week. It has to stay on for 6 to 10 hours, and you have to do about 16 weeks total of therapy. So it's not the most convenient product on the market. Okay, moving on to antifungal therapy. Antifungals are really only going to be seen in a couple different, or really the use should only really be seen on a acute scale in a couple different groups of patients, and really going to be immunocompromised people are at risk for systemic fungal infections. Not to say, people can get fungal infections on their skin. There's, of course, with women, vaginal yeast infections. So there's other uses, and we're going to talk about those things, the more common ones as well. But as far as our broad spectrum approach to fungal infections, it would be very unusual, I think, in your practices to see IV antifungal use. But if you do have a patient who is immunocompromised, or you work with an immunocompromised population, it wouldn't be out of the question to kind of think about it in the back of your head. Fungi are yeast, molds, mushrooms. So yeasts are unicellular, molds are multicellular, and they do have a cell wall, but it's made of different material than bacterial cells, so we don't use our antibiotics for these pathogens. A couple different pathogens we're most concerned about. Candida, which is sort of the ubiquitous one. We think about that as your thrush, your standard yeast infection, whether it be oral or vaginal. Can get disseminated too. You can get systemic Candida infections too, which can be easily treated or actually quite resistant. There's a couple other things that most of these are going to be pulmonary infections is what they're going to is where they're going to take up root, and these are again going to be immunocompromised patients are going to get this. There's fungus all over, especially like something like aspergillus, which is essentially everywhere. Blastomycosis and histoplasma are common in our region of the country, and there's other things too that we get exposed to on a daily basis that ultimately we don't really worry about because most of us have functioning immune systems. It's really the immunocompromised we're concerned about. This is just a diagram that shows how our different drug classes work. And I'll up here. Okay, so when it comes to antifungals, a lot of this is for your reference. I'm not going to ask you really substantial questions about antifungals because I really think it's not necessary for your scope of practice. I'd much rather you focus on antibiotics when it comes to studying, but this is just for your information. Amphotericin B is a really broad spectrum antifungal. It's an IV product. Historically, it caused a lot of problems with kidney toxicity, but they've reformulated it, and now it's a lot better for the most part. And that's really all I want to talk about Ampho B. It's very broad spectrum and essentially covers everything. So if you have a severe fungal infection, this is something you may see used. Azole antifungals, these are probably the most common class of antifungals. The one thing to think about with anything azole, whether it be just a one-time dose oral of fluconazole or diflucan, you're looking at major CYP enzyme interactions. So these are extremely potent CYP enzyme inhibitors, and so we do want to make sure we aren't messing around with our other drugs to a substantial degree. And the spectrum of the activity varies widely. Some of these are very narrow spectrum, others are very high spectrum. Generally, we avoid these during pregnancy. However, topical use may be appropriate. So, like a topical, Miconazole cream or something like that for a vaginal yeast infection might be appropriate. All right, so fluconazole, but here it's got a long half-life. That's why we can get by with a one-time dose for any type of topical yeast infection. It's also available IV. It's used good for empiric Candida infections. I'm going to skip Sporanox. It's there in case you want to read about it. Voriconazole is our go-to for invasive aspergillus, and it's a pretty potent broad-spectrum azole antifungal. Posaconazole is an oral one. Again, I'm going to skip. The next class we have are echinocandins. What these do are broad spectrum, very well tolerated drug. They don't have a lot of drug interactions, except for a couple things that I've listed down there. I would ignore those for the purpose of what we're talking about today. They are IV only, and again, just think about these. These are broad spectrum. Something's resistant. If you had like a patient who was in the ICU and they've got broad spectrum antibiotics and they're looking at adding something for fungal infection, this would be probably a drug they would choose, something in this class, and just go straight to an echinocandid because they're well tolerated and they're very broad spectrum. Other agents, topical stuff, so clotrimazole and miconazole, available as topical creams. So these could be useful for any topical fungal infection, which would be things you consider like what we'd call ringworm or jock itch, which are tinea infections. Athlete's foot, also a different type of tinea infection. They're available as vaginal creams and suppositories like Monistat, and these could be useful for those. And the systemic absorption of these should be very minimal, even when used vaginally. So in pregnancy, I think in most cases it'd be okay to treat a vaginal yeast infection with one of these products, and you can really not get too concerned about having a substantial, if any, systemic absorption. And terbinafine is just another topical over-the-counter antifungal. All right, so again, this is just a reference point for you. In case you want to know about our different drugs here, you can look at this and compare, okay, so what covers what and which ones are more broad spectrum than others. And yeah, but again, not going to test you on this information. And then here's some toxicity issues too, again, for your reference. All right, we'll talk about anti-malarial products. Maybe something you encounter in primary care when you're, if you have patients who are traveling. I think it's good to just discuss it. Malaria is a really common illness across the globe, and a lot of people die a year for malaria. So it's actually quite deadly, and there's not a lot of adequate treatment in certain areas of the world. So it's really important that if you have a patient traveling to somewhere where malaria is endemic, they get prophylaxis appropriately. This is just an example, a screenshot I took of the CDC data. So they have CDC has a great reference for all your malaria information, and you have the countries. So if somebody came to you and they're like, I'm going to travel to Afghanistan, then you can say, well, it's high risk for malaria for U.S. travelers. Drug resistance has been shown to chloroquine. So that gives you some information about, okay, so this is how I would treat somebody. These are the species I'm looking at. And we've got recommended prophylaxis options there. This is for the malaria stage that it moves through. So you have a bunch of different stuff going on here. You have transmitted via mosquito, and then you have it taking up residence in the liver, getting the liver cells ruptured. You get it into the blood, and it can be problematic from then on. So you can go over that in more detail if you want. So traveler prevention, the regimens vary a lot in cost, doses, and adverse effects. So there's a lot of things to consider here. And then, of course, you want to make sure, first and foremost, that it's a recommended regimen for your area and that you aren't prescribing something that's resistant. There's a study done in 2009 of American travelers who took prophylaxis for malaria, and 90% of them took an ineffective drug, or took their drug inappropriately, or didn't take the drug at all. So it's important to educate people on the necessity of really taking this seriously, because malaria can be pretty nasty, and we don't want people to get exposed to it, of course, and we want to educate people. So that also comes into play with the regimens we have out there. Some are much more convenient than others, and some, when we go through these, I think you'll see why people don't take them. So talk about Malaron. Malaron's probably by far and away the most commonly used anti-malarial prophylactic agent. It's a very easy regimen. You take it 1 to 2 days before, you take it during, and you take it 7 days following. You take it once daily, and again, very easy to remember to do it. And you can time it out so that the person's just taking it every day, and then they're going to be, when they're done, they're done. They're out of their medication. So just take it until it's gone. You don't really have to think about the timing that way. Pretty well tolerated overall. GI effects like nausea, maybe some diarrhea are probably the biggest ones people report. If people don't get that with Malaron, they probably won't get any side effects with it whatsoever. Malaron's one of the newer agents, and it doesn't really have a lot of pregnancy data out there. It's not a recommended option in pregnancy, and that may change, but again, it likely is probably safe, but we just don't have the data to really make that recommendation or not. Mefloquine, on the other hand, has good data in pregnancy. The recommendation for this dosing is not ideal. So you take mefloquine once weekly, start 2 to 3 weeks before, and take for 4 weeks after. You can see why people would just not do the whole course or would forget. And 4 weeks after you return from a trip is a long time to keep taking medication and to keep remembering, especially when it's once a week. And most of the time when people are taking something once weekly, it's a lot easier to remember to take something every day than I think it is to take once a week. So you have to set a reminder system to yourself or something on your phone or whatever to make sure that, oh yeah, I got to take my mefloquine today, so you don't totally forget about it and miss a week. Unfortunately, mefloquine, even though it's tolerated well in pregnancy, it's not tolerated well from a side effect profile. And the biggest things here are these psychiatric effects. It has some GI upset, maybe some other things here, but difficulty concentrating, mood swings, strange dreams, and some people even get really severe psychiatric effects. Like it can worsen anxiety, depression, nightmares, paranoid ideation. It's more commonly seen in women than in men, these side effects. And you could consider starting, if you were concerned about this, which you might want to be, especially if you have a patient who has even a mild psychiatric history, maybe they're taking an antidepressant or they have a history of anxiety, give them, you could start it like 4 weeks prior to travel. You can assess how they're tolerating it, and then that still gives you a decent buffer to switch to something else in case you have to change therapies because the patient's not tolerating it. Doxycycline we talked about as an antibiotic, so this is also useful for malaria. It is contraindicated in pregnancy in children for reasons we talked about during the last lecture. Recommended regimen 1 to 2 days before, 4 weeks following. You take it once daily, or twice daily actually. So it's a really long regimen. It's poor compliance due to the twice daily dosing, and not ideal. It's pretty well tolerated medication. The one problem is sun sensitivity. So anyone going to a warm area of the world with a lot of sun, which is probably at most places where malaria is more endemic, may end up getting increased sunburns or problems like that. So just something to be aware of. Chloroquine is safe in pregnancy. It's a once weekly. Start 1 week before, 4 weeks after. It's pretty well tolerated. It's safe in pregnancy. And so assuming your area is not resistant to it, you could consider chloroquine. Primaquine is contraindicated pregnancy and breastfeeding, but it's a pretty easy regimen, kind of like Malarone. I just put this on here for your reference, this last part, treating active infections. There's a couple drugs we actually have that can treat an active malaria infection. However, these are restricted to basically to the departments of health or the CDC stockpile. So if you really want these drugs, you're going to have to go through a lot of channels to get them. We've had a couple of cases at our hospital where we've had to treat malaria, but we've had to go through special back channels to actually be able to get the drugs. So they aren't widely available. Okay, finally, I just want to talk about a couple of parasitic infections within parasitic world and within the fungal world, but I really think it's limited in scope, and I don't think it's really worth going into. So I know I went through a lot of this kind of fast, but I focus on the major points, especially with the HIV and antiviral drugs. With antifungals, just know kind of what azoles are used for, what the different classes of the medications, which ones are broad spectrum, which ones are narrow spectrum. That would be some standard stuff to know probably, but not going to be a ton on specifically antifungals, because again, especially with IV antifungals, it's beyond most people's scope of practice. Really, if you're looking at prescribing an antifungal, you're probably either looking at A, you're working with immunocompromised patients regularly, or B, you're working in conjunction with somebody who's an ID specialist who's recommending it. So keep that in mind, and let me know if you have any questions. Thanks. And that's all I really want to talk about. There's other things